afternoon. Hello. Okay, I'm Betty Bibbins, and this is going to be interactive. This is going to be a 45-minute introduction to is your documentation ready for ICD-10, just to give an overview. The first thing I want to tell everyone, breathe in, breathe out, okay? I have a blog that I do, and for October, it's going to be an interesting blog. It'll be very short, because I'm going to let you get to ICD-10 when it begins, okay? This is just a general overview. I could talk for literally weeks on what the specifics are, but we won't go there today or this afternoon, but it will give everyone an idea of how they need to start thinking. And it's not all that different. It really is not. We just need to get more specific and explicit, and I'll go through that in a second. Our objectives, no objections today. Objectives, it's going to happen. Some people are still crossing their fingers and sticking their heads in the sand and say it's not going to happen. We got 2 congressional amendments out there to try to push it off to 2017 or 2018 or 2020. Thank you. 2050 ain't going to happen, okay? And breathe in, breathe out. All right. Introduction discussion of how ICD documentation, and one of the things I really need to emphasize is I do not talk coding. Do we have any coders in this room? Anyone certified in coding or who does coding for themselves or anyone else? Good. I don't talk coding. The coding I give are generalizations because I am not a coder. Everyone talks about fraud and abuse, inappropriateness of coding. They forget that's the second step in how communication of healthcare is done. The first step is that you gotta have something to code. That is where the problem is. We in healthcare, we physicians, and to a degree some nurses, but nurses actually do better documentation than physicians do. But that's another week of discussion and presentation. Physicians, we have been taught to practice medicine. A majority of us have not been taught how to appropriately document the practice of medicine so that third-party payers, including the U.S. government known as CMS, known as Centers for Medicare and Medicaid Services, can understand what we have done. They started on the coders back in 1995. With inappropriate of coding. That's where we first heard about fraud and abuse, that we go to medical school just to become fraudulent and abusive of the healthcare system. Right, give me a break, okay? They started with coders because coders knew what we meant, even though we didn't say it the way third-party payers, including insurance companies, wanted us to say it. The words and requirements have been there since 1982 when they start. Well, I'll say 1980 because technically the laws were passed and rules begun in 1979 October 1st, as I've been informed a number of times, but we really didn't start doing it until the early 80s. Okay? The rules that we are now being penalized for have been there since that time. They just started enforcing them in 1996. And now, whenever we get good in one area, they have other ones that have never enforced that they're now enforcing. None of this stuff is new. It's been in the hundreds of pages of conditions of participation that every physician or physician group has to sign before they can join a healthcare organization and get paid by it. Any third-party payer, any private insurer, as well as CMS, has requirements of what you need to do to provide care to your patients for them to reimburse you. And they also have the caveat that you don't have to follow their rules. As a physician, you are an independent individual, educated in the right way to practice medicine, and you can practice medicine any way you desire, any way you want, any way you see needed. One detail, if they don't agree with how you communicate it to them, they just don't have to pay you. Okay? So no one will ever tell you you're wrong. They'll just withhold payment and say you didn't follow our rules, which are the right way to do it. Detail, okay? So we're just going to go over some of the requirements that are literally just an add-on to what we are supposed to have been doing for the past 30-odd years as far as documenting the practice of medicine. Okay? Big point here. Embrace the ICD-10 mandate. Okay? Some people don't think they really need to because there's hope. They will feel like there will be a last-minute saving grace and it'll change. I don't think so. I'm not going to say it. It's not 100% definitive, but short of what, a Hail Mary? I don't think so because there are too many of them been going up lately. We need to just get adjusted to it. We can accept it, embrace it. It is part of medicine. Medicine is changing from the way we have done it since the 1960s, which is over 50 years. Anything that does one thing for a long period of time needs to mature, needs to grow as medicine has grown, and we'll go through some of the points of how it's grown. Okay, effective clinical documentation does not mean more. It just means more specific, more detailed, and more explicit documentation of severity of illness and medical necessity. One thing we also have to keep in mind, areas such as medical necessity and to a degree severity of illness, yes, they are by medical standards, but medical necessity does not always go with how, again, we've been taught to practice medicine. One of the greatest points that we have now that I've been giving seminars and talk after talk after talk after talk on is observation versus inpatient. A lot of physicians are still feeling that whenever you put a patient in the hospital, you are admitting that patient. And yes, you are, but you are admitting to inpatient or placing the patient in observation, outpatient observation. And there's a big difference. But the problem and the challenge is that it is not a medical difference. It is, to a degree, a slightly arbitrary differentiation based on finances. Okay? A lot of the differences that we see between practice of medicine and documentation of medicine is cost. What we have sworn not to be concerned about when we practice medicine, but now we have to take a step back on that because that is how we are graded as quality of care, because so much of the Medicare Trust Fund is saying it's going to be bankrupt anywhere from 2020 to 2040. That's within a few years, and no one wants that to go bust on their watch. So in order to preserve the Medicare Trust Fund, and also theoretically to keep healthcare prices reasonable, what we're doing is they're teaching us to document, to capture not only appropriate care being provided and the necessity of hospitalization and care, but defining hospitalization as whether they just need to be in one day or need to be in longer. It's simple as that. And that 2 midnight rule, has anyone in here heard about the 2 midnight rule? Okay. Let me ask you a question. Are majority of people here inpatient or office, ambulatory care, clinics? Hands for inpatient. 1. Hands for outpatient clinic, ambulatory care. Got it. All right. You are still impacted to a degree. I won't go into major detail today by some inpatient care because a lot of emphasis is placed on pre-admission documentation of care provided that makes elective surgeries required and needed, meaning how much pre-physical therapy. If you have a total knee or total joint of any sort that needs to be replaced, how much medication was tried for how many weeks? How much physical therapy was attempted for how many weeks? How many other therapeutics were tried for some X number of weeks prior to surgery rather than going straight to surgery as the first option? They have had major joint replacements that were elective, impacted just because something as simple as the joint was painful was never mentioned. It just said it was needed. It was never in an outpatient chart. It was never said that they were said there was some mild arthritis there, but it was never noted to impact the activities of daily life. These types of documentation in the office are needed in the inpatient setting in order to be pre-certified to be okay to do those surgeries. So there are a lot of inpatient components because as we go through the new forms of medicine, Affordable Care Act was passed. Along with that, you are the future of healthcare. As we all know, healthcare in the past, and today to be exact, won't even say the past, today, the emphasis is on specialized medicine. Those in primary care and ambulatory settings are not the top of the pecking order because specialists are where everybody wants to go. Okay? That's where the income is. No ifs, ands, or buts. That's where the status is. Okay? But with the Affordable Care Act, the emphasis is coming back to primary care, preventative medicine. Things are being shifted back to the home of healthcare, primary care, outpatient setting. Let's keep the patients from having to be placed in the hospital. Let's do everything we can. We're going to shift a lot of major components that are now inpatient post-op type of care into preventative medicine. So this is not going to be a small shift. This is going to be a major, quick change with accountable care organizations evolving now. How many have heard of or are participating in an ACO, accountable care organization? Okay, today it's 3. Next year it's going to be more. I give 2 to 3 years before it's going to be close to 100%, because that is how payments are going to be made in the future. They're going to give all the money to an accountable care organization, and then the accountable care organization divvies up the incomes. Okay? So this is why we have to know how to document so that we get our appropriate share of the care, the payment for care. Because that payment just doesn't include patient being sick, patient getting some outpatient care, patient going in the hospital, and patient going home. This includes pharmacists. This includes occupational therapy, physical therapy. This includes home health care. This includes nursing homes, assisted living. This includes an entire episode of care from the initial onset of any sign or symptom all the way through till the patient is completely recovered from that, even if it includes rehab, home health care, or rehab, skilled nursing facility, home health care. It goes through the entire episode of care. So money is going to be tight because literally they're just throwing out one bundle of cash and everybody gets paid internally from an ACO for that care. And so it's going to be a member of an ACO or be out there fighting for yourself, and that will be very, very hard to do. So there what's going to be coming up because, I mean, how much can be done in the, 2 to 3 weeks since the Supreme Court affirmed that affordable care is here. So that's going to be, I'm going to be, if I'm here in the future, I'll check and see how many are with, say, ACOs, because that is the wave of the future. So at least get to know about them. They're going to help you. Okay? Now, 68,000. Everybody's heard there's 68,000 codes. Oh my gosh, how am I going to learn them? Number one, you don't need to learn 68,000 codes. All we need to know is how to explicitly and succinctly document our care provided. And the coders with their computers code. Physicians and support staff for physicians document. One example, one diagnosis, congestive heart failure, the number one medical diagnosis in the United States per CMS. There are 4 words: systolic or diastolic, acute or chronic. Those 4 words will extrapolate out to 21 different ways of putting these words together, with one just being heart failure. You just say heart failure, that is the bottom of the barrel. And then by every time I explain it this way, every time you add a descriptive, appropriate adjective, you are increasing the specificity, which increases the value because it increases the work you've done and it gives more specificity on how much care you needed to do to take care of that patient. So when you say just acute CHF, that doesn't mean an awful lot, but it means more than just CHF. But you say acute systolic or acute diastolic or acute systolic/diastolic CHF, you've hit the mother lode as far as that diagnosis. You've captured all the differentiation you can. You can say chronic systolic or chronic diastolic or chronic systolic and diastolic. You see how we're starting to merge? You can say acute on chronic. This is when a patient has a diagnosis like CHF, it does not go away. It is either acute or chronic because you're utilizing some form of treatment as well as usually a low sodium diet to go along with it. You may or may not. It just depends on your management style. So when you say once a patient has CHF, you need to determine whether it is systolic or diastolic, and if it is, then you determine it's chronic from that day forward. It may not be asymptomatic, or it may be asymptomatic, but it is still chronic because it's there and asymptomatic. Because take them off their medication, take them off their diet, and it becomes acute. They start having symptoms, and you have to then manage them. Sometimes outpatient, sometimes they have to go in the hospital, and this is totally preventable. Okay? So, and then you have acute or chronic. It's when they've had it for years and they have a flare-up. They've gone off diet, gone off medication. A number of things can happen. And that is all embedded in the terms. So just by using 2 additional words to what you already use can significantly increase your reimbursement because it's showing that there's increased care needed to take care of that patient because of the specificity. You're telling a lot of non-physicians that you are utilizing a lot of resources to take care of your patients. So don't let 68,000 codes bother you because you're not going to use all of them. The odds are you'll have 20 to 40 diagnoses you take care of all the time. Learn how to document them. And again, you don't need to know how to code them. If you're not coding them today, you're not going to need to code them for ICD-10. You just need to know how to document them completely, explicitly, succinctly, with the correct words. And the words are just adjectives, descriptive words to give you more depth of knowledge of what's going on with this patient. Okay? Clinical specificity in diagnosis, regardless of setting, is crucial to communicating how much effort it takes to take care of this patient. And that is what medical necessity is, showing that what you're doing, i.e., when you have a patient who you have pneumonia. Okay? Pneumonia can be anything from walking pneumonia that you take care of in the office to a patient who has pneumonia, who is in acute respiratory failure, who is on a vent in a hospital in the process of expiring. So think about it. Pneumonia. How sick is that patient? But pneumonia with hypoxia or hypercapnia, severe. Okay? We're starting to get a better picture of the patient versus pneumonia with minimal hypoxia or no hypoxia. It's just that it's ID'd on the x-ray and the patient comes in with a cough. All right? Your care is needed more in a more complex ill patient, and that is what you do through appropriate documentation. Now, these are just some of the comparisons, and again, this adds up to that 58,000 codes. Right now, in ICD-9, today, when someone has tobacco abuse, meaning they use tobacco, There's just one code for it. In ICD-10, there are 5 codes for, quote, tobacco abuse. Now, these codes come from not just you're using tobacco, but how are you taking tobacco into your body? Okay? Is it smoking? Is it chewing? Is it by patch? Is it secondhand smoke that you're not smoking? Is it secondhand smoke in your home? Is it secondhand smoke in a work environment? This is how the specificity comes out. This is how ICD-10 will work along with affordable care and accountable care organizations in how sick the patient is, which will determine how many meds you need to use, how much care the patient needs, inpatient or outpatient, whether it's short period of time, whether it's prolonged period of time under any form of care. You're starting to get to specificity and chronicity of diseases. Okay, diabetes. We now have 10 codes for it. You got diabetes. The type diabetes and whether it's controlled or uncontrolled. End of discussion. Which doesn't always tell you an awful lot. It goes up to 318 codes. But the codes aren't that bad. The codes are complex. But that's why coders have computers to tell them when they have the documentation to write. These codes in diabetes now can be complex codes. All you have to say is diabetic, type 2, controlled or uncontrolled, who has peripheral neuropathy and or retinopathy, and then the type of retinopathy. Okay, do they have renal failure? Is it acute or chronic? We start getting into complex. So you just describe what's going on with your patient. That's what I'm trying to say. Long story short, you describe not only that the patient has diabetes, the type of diabetes, whether it right at this point. If you can say, I don't know if it's controlled or uncontrolled, what is your thought today when you're writing this note? Do you have the A1C in front of you? Do you have the blood sugar of the day in front of you? What is your clinical judgment as to the severity of illness of this patient? And then what other complicating comorbid states are there secondary to the diabetes, even if they are stable or controlled? There's a difference. You can have 3 or 4 or more CCs, chronic comorbid complicating conditions secondary to the diabetes that the patient has, but not all of them may be flaring up at one time. But they're still there. So it shows you have to think about them because you have to use medication. If the patient has their peripheral neuropathy kicking in, then you need to give them meds that won't impact their chronic kidney disease, because if it can't be excreted, then you have to worry about your patient going toxic on you, and do you have to do multiple tests to make sure your patient's not getting toxic on you if the only option you have is a medication that's excreted by a poorly functioning kidney. Okay? We just need to wrap our brains around it. Okay? All right? Fracture of the radius, a fracture of the bone. It goes from 33 codes to 1,800 codes. Breathe in, breathe out. This is because this is the type of requirements are what every surgeon has to think about before they can determine what management is needed. We just have to start writing in the medical records what we have to think anyhow. Where's the fracture? Is it a compound fracture, a simple fracture? Okay, what part of the bone? Is it medial, distal, proximal, lateral? Sometimes they don't even say what arm it is. You got to say left arm or right arm. Think about it. Patient came in with broken limb. Okay? All right. So this, again, complexity. There are 10 different points where every bone, when there is a fracture, need to be addressed or just stated is not relevant. And with that, you capture the complete specificity of that fracture. Okay, there's a 7th character extension in some areas. Basically just says you have to say within your note whether it's an initial visit, whether it's a follow-up or subsequent visit, whether it's a sequela, secondary, you see a patient after they've been treated and then they have side effects or problems or complications, and then whether it's aftercare. This just, you have to say within your note, and the coder will code this and add it to the extension. Just need to say it and think about it each time you see a patient, especially new patients. Okay, specificity is an ongoing component, with the largest and most important component at this time until they find something else to get us for is medical necessity. Once we get medical necessity down, trust me, again, there are thousands of pages of conditions of participation and they'll find something else. But let's just do it step by step and just take care of medical necessity as defined by third-party payers, especially CMS, is what the patient needs for the severity of illness they have. You don't need to use a $700 a dose antibiotic for a mild pneumonia. However, if a patient has a significant pneumonia and it is documented and captured as such, then yes, it does justify it. There may be in evidence-based medicine a protocol of how you provide care for a patient. And then you go to step 3 as the initial treatment and you go, oh no, you get kicked back that you didn't follow protocol, so they're not paying you because there was no medical necessity for the medication or the treatment that you did. But you just need to document. The patient may be allergic to the first and 7 levels of medication. Okay? You may have tried it before and had failed management, especially failed outpatient management with the medications that were there before. Or that it impacted the patient or impacted their safety or impacted the activities of daily life because it made them too groggy that they couldn't function and they were living at home by themselves and they fell. This is all you got to document and then do what you need to do. When we just go to it without telling why we're going to a more expensive or more complex level of treatment without mentioning it, not a paragraph, 1 sentence, patient allergic to, impacts and activities of daily life because of impacting level of consciousness or whatever. We just need to note it because what third-party payers want for capture of quality of care, to make sure you're providing quality of care, which in their eyes is basically value over cost. You're getting a good outcome at the least cost because there's not enough money to go around. End of discussion. We have so many different definitions inside of medicine. Yes, you do what you need to do for the best outcome. And a lot of these medications are the best things out there, but do you really need to try a brand new, hot off the grill antibiotic when $1 a dose, multiple generation cephalosporin might just actually take care of the patient? Okay? And yes, it's sure that those new medications will work, but does your patient need it? And all you need is 1 or 2 sentences to justify it. Okay? Specificity matters. I'm just going to, I have some of these, a number of slides to just give you some of the generalities, and you can download the slides and use them as kind of a reference of just how you would document things. Like nausea in ICD-9, just nausea with vomiting, nausea alone, vomiting alone, or bilious and emesis. Okay? That is the totality of no matter what we write, it goes in one of those 4 areas. In ICD-10, this is just a part of the 20 or 30 different combinations you can have. Because you take any one part of this and put it with another, and that becomes another diagnosis. But all you have to do is write what your patient has. You don't have to worry about everything under the face of the earth. You just need to document what's going on with your patient today, and that will fall in the code in ICD-10 that it needs to fall in. Is there vomiting? They love the word unspecified, and meaning, is it you have different types on the vomiting alone. Is it projectile? What is in the vomitus? How often have they had the vomitus? You see, those are some of the components that are not up here. So if you just say, ask the patient, what's happened to you? How long has it happened? And just jot it down. That will capture the severity of illness of your patient. Vomiting without nausea, projectile vomiting, like I said, vomiting with fecal matter. Just ask your patient, what type of vomitus have you had, or look at it if they're still doing it in front of you. Okay? Nausea with vomiting unspecified, vomiting following GI surgery. Okay? Specifics, specificity, succinct. All you got to do is just put those adjectives down, and that captures the severity of illness. AFib, all the different types of AFib. Okay? I'm not going to read everything to everybody, but the different types, we just need to be specific when we write them. And when it really helps to do this information either the first time you see the patient or immediately upon reviewing if you decide to do an echo and you get the echo results, and then it becomes part of the medical record list of diagnoses that will always come forward. So you won't have to worry 3 years from now what type of AFib this patient has. And that's another point we need to push out. When information comes, get the explicit diagnosis as soon as on there, so that any physician who gets it in the future will have the specificity they need. And like I said, with CHF, a lot of times no one knows, because we really, a number of years ago, did not have to have whether it was systolic or diastolic. Okay? Systolic, usually if the patient also has hypertension. Diastolic, usually if the patient has hypertension. Systolic, if they just have a weakened ventricle. Okay? If you don't have explicitness, you can use that as a general guide. Possible and probable, you really can use, because patient has hypertension also. Okay? Probably secondary to hypertension. CHF, chronic CHF, probably secondary to hypertension, if you don't have an echo. Okay? So we have the types, and anytime you just say aflutter or AFib, it's going to go to unspecified, which is the least you can get, which means essentially a patient doesn't have anything that's acute, there's nothing's going on, and you're basically going to get paid equal to or less than a level 1. No matter how sick the patient is, if you don't put the adjectives up there or the specificity, you won't get paid for it. You can do anything you want. You can write anything you want. In fact, they love it because they don't have to pay you. Okay? So you can just not do anything ICD-10 and have everything that you write be unspecified or just considered a sign or symptom. And there are other jobs that you can do part-time on the hours that you are free from your office. Okay? And insurance companies will love you. And your quality of care will be on health grades, et cetera, down through the floor, but at least you'll feel good within yourself, because a lot of docs are saying they're going to fight it to the nth degree, and I said go for it. They're praying you will. Okay? Non-compliance. This is a new one. You can actually tell why your patient may not be getting better with all the care you're providing. Okay? Because, and this is just a fraction of the non-compliance, types of non-compliance that are there. So all you have to do, you don't have to worry about the ones, what type of non-compliance is it? Just document what's going on with your patient, and the coder will figure it out. If they have nothing to follow up on, the coder can't figure it out and just say non-compliance, not otherwise specified, which is just like saying you don't even have it. Okay? Point. Patients' non-compliance with dietary regime. This is when you have patients that need to be on a low-salt diet and are constantly eating salt. Okay? Think about it. And no matter what you do, they don't get better. Okay? The hypertension stays up there. You need to start. They can be diet controlled if they would just do a low-sodium diet, but they won't do a low-sodium diet. So you got to then start using more medication. That costs more to the healthcare system. So you're letting them know that you're doing your best, but the patient has said, I don't like it. And so just document non-compliance, dietary, and it will be captured. And this will go for you to show you're still providing quality of care, but the patient is not doing their part of it. That we've known happens a lot, and we have not had any way to communicate that. We've written it in the chart, but guess what? There was no way to code it under ICD-9. Because back in the good old days in the 1990s, no patients were non-compliant. Okay. Now we know they are non-compliant. But there are other reasons. Non-compliant, intentional underdosing. Because the biggest one, financial hardship. They cannot afford the meds. If the patient says that, because a lot of times they tell us stuff in the office, there's nothing we can do with the information other than say, well, try. But they can intentional underdosing for other reasons, and you put down the reason, and I'm sure there's a sub number down there. I just put the top and the bottom ones. Underdosing, intentional, because of age-related debility. They just keep forgetting. They live at home by themselves, and they just keep forgetting to do it. Or they have the resources to pay for it, but they don't have anyone to get the meds for them, and the pharmacies don't deliver that much anymore. So they can't get the meds except when they get out once a month when somebody comes to give them a ride. And they may run out of meds, or the medication may be for like a 3-month refill, and they aren't delivered at home, and the patient can't get that odd number. Okay? And so things like that. And patients unintentional underdosing due to other reasons. So just put the reason down. There's a reason for it. I think there's even more. Okay, yeah. There are a bunch of reasons. And so just put it down. One sentence, not a paragraph. We're talking one sentence here, one sentence there. But you're saying something other than just shooting a breeze in the chart, because that's what it boils down to. If the coder doesn't have anything to code, you're not writing anything in the chart, because the only thing that leaves the office are the codes. They don't send charts out except when they're asking for your chart so they can deny even more. When they ask for a chart and there's nothing on there that they can pick through, they're looking to take even more off from what they're paying you. Okay? Reality, medical decision making is a proxy for medical necessity. Why we're doing what we're doing is the most important thing. Just jot down why. Take one word out of here. Why are you doing what you're doing for your patient? How sick is your patient, and what are the different options, and why are you picking the option you're picking? 3 sentences, not 3 paragraphs. Okay? They don't want to read it. You don't want to write it. Don't do it. Keep it short and sweet. Clinical specificity and clinical judgment. They actually do pay us. They recognize that we have intelligence and that we learn something in the medical school and residency programs that we went through. And they actually pay us for it. But guess what? We don't usually put that on there. We think things through. We have to think things through to get to where we're going. Okay? When we have a differential, we have to go, our brains, just like a little computer. And then, or big computer, depends on your brain. Okay. Or one perception, one's brain. But anyhow, okay. And then we come with a diagnosis. All right? Put a couple of those points down. You kind of let them know how you got to where you are. That's what they compensate us for. Our care and our thought. Not only what we do, but how we got to what we're doing and why. Okay? This supports conclusory statements. In my clinical judgment, patient has this diagnosis. And they see how you got there. Just like when you took algebra and calculus. The answer it was not what was important. It's how you got to that answer is what they wanted. That's why they always wanted to see the work. Your answer could be way off of Wawa land. It's just that you mixed some numbers up when you did basic multiplication. But you did the process right, so you still could get at least a 90 or 95 on something. Okay? This is taking this another step. We're taking it into the logical component. Okay? And we must have our documentation to support medical necessity. Now, for the last couple of minutes, I'm just going to go over the requirements. These are some of the words that, if you get nothing else out of this, use these words on as many diagnoses as you can, at least getting you in the right direction. If a diagnosis is acute, if it's new onset, acute. Even if you say, I don't need to say acute pneumonia. Well, there's some people that do have chronic pneumonias. Some people who live in nursing homes who chronically and constantly aspirate. Think about it. There could be a chronic pneumonia. In ICD-10, this allows you to make your diagnosis what it is. It doesn't make you fit the system. ICD-9 was good for its time back in the 1900s. Isn't that something? To think about it, back in the 1900s, it worked. We're still using it in the 21st century. And so what we need to do is put, even if it doesn't make sense to us, it will to your coder. And if it doesn't to your coder, give your coder some ICD-10 training, okay? Acute on chronic. If someone has a chronic disease and you have a flare-up of it, it's either acute on chronic, or you can say accelerated or exacerbated. Use these words, okay? It can be uncontrolled, decompensated. Uncontrolled diabetic patient always is it controlled or uncontrolled. Okay, any chronic disease, is it controlled or uncontrolled? Is it acute? Is it chronic? Put those words on there. That shows whether you're steady stating your patient or whether you're actually doing something that needs to be done for that patient. Okay? Malignant, such as hypertension, not just malignant as in cancerous. Okay? Accelerated, such as hypertension also, or any process accelerated. Is it end stage? If anything is end stage, please document that so that everybody on the face of the earth who touches this patient knows, because that means that there may not be overutilization of resources that are not going to work because the patient is end stage. We've had patients come in with a minimal history, or the history of just said like CHF, and then when we finally days later got the charts notes from the physician's office or communicated with them, the patient was end stage heart failure, and everybody was wondering how we could not get this patient stabilized. When the patient was first seen, if that diagnosis had been known, days of overutilization of resources would have been saved. The patient would have received appropriate care for the severity of illness, because a lot of patients don't go to the same place all the time. Even those that live in one area will bounce around to different hospitals. Okay, and so it needs to be seamless. And with the way HIPAA and meaningful use of computers, it should be that when any information is captured in an office, it is immediately available if that patient goes to an affiliated or associated hospital or any other level of care, and they know the exact diagnosis of what's been going on outpatient. And you know immediately, not days later or a month later when the physician dictates the H&P, not H&P, but the discharge summary, and you get that when you get it. But you get it the moment the patient comes out of the hospital, because technically it should be done then, and they're pushing more to get them sooner than later. Okay? This should be seamless, and you know what's going on. Okay? When it's worsening or improving, that's good in any encounter. If you're seeing a patient multiple times and you just say they're coming in for one diagnosis, is that getting better or worse? You'd be surprised how you just write down what's going on, but in your clinical judgment, is it better than what it was, or is it worse than what it was? Because it can still be getting better, but still bad. You have varying degrees of bad and varying degrees of better, including resolved. And we don't see that an awful lot in charts. If something is acute, is the acute state resolved and they're back to their chronic state, which means steady state. Okay? This is how third-party payers and how the profilers that are profiling every patient that we see now and putting it out there to the patients and on the web of our, quote, quality of care. We have to justify what we're doing. And it's out there. Go look yourself up. It's up there in health. What physicians compare and hospitals compare, it's out there. And every insurance company that you accept payment from, they have their own profiles of you. Ask them what your profile is. Okay? Ask for it. Sometimes they give it to you. Sometimes they give you a fight. They won't, because they consider it internal. But that determines what they offer you for compensation when you redo your contracts down the road. So it's nice to know where you stand so you can negotiate. Okay? Because they are actually thinking and talking about two different things. If patients don't meet, if providers don't meet certain standards, they will either make patients have higher co-pays or higher deductibles for coming to you for care, and this then encourages them to go to other physicians. We've had patients go across a county when a deductible, instead of being $10, it was $25. Well, a copay was $25 instead of $10, or the deductible is $500 instead of $150 or $250. That makes a difference to a lot of people. Okay, so we got to keep stuff like that in mind. And also for patients in a hospital, whether it's present on admission, if you see a patient in your office with various diagnoses, put them in your chart in the office. So even if it's missed in the H&P of the hospital, if they need documentation to support it was present on admission, they can come back to your record. Because hospitals get paid nada, zero, for any care provided for a diagnosis, certain diagnoses that are not present on admission, because the only thing they can say is that it was hospital acquired, and if the hospital caused it, the hospital has to suck up the cost because they weren't providing good care. And that could be tens of thousands of dollars. If a patient comes in, oh, I know this won't happen, a patient comes in, heaven forbid, with a fracture of a joint, and it wasn't noted on admission. So then the hospital gets accused of being hospital acquired. Obviously, the patient fell since it wasn't mentioned on H&P. Patient fell, obviously, and the hospital has to pay for anything regarding the surgery done. They still pay the physicians right now, but they're trying to get around that. Okay? They don't pay for any hospital costs, so that includes acute care, rehab care, and any other care the hospital provides it has to absorb. That can be $20,000 for a total hip. Okay? A patient come in, and then on day 2 of admission is not noted that the patient had this diagnosis on H&P. So on day 2, when they finally turn the patient over and find a stage 3 or stage 4 decubitus ulcer, guess what? You know that can't happen in 2 days, but if it's not documented somewhere, even a link back that this is what was found now, how it was present on admission and just was not in the H&P, or do an addendum to the H&P, the hospital will not get a penny for all the surgical debridement and all the care, nursing care, wound care, anything that goes along with that. They don't try to think anything through. If you don't put it in, they don't try to put 2 and 2 together. They can see 2 and they can see 2, but if you don't say 4, it doesn't exist. End of discussion. They're not paid to use their brains. They're saying we are. Okay? Nosocomial or resolving. And one on here, it's on my other slide, but it's not on here. And I had to defend this one initially, so I went on and had to define it. Dominant versus non-dominant. So someone said, what does dominant have to do with a patient being sick or not? I'm saying, excuse me, person. Number 1, get our brains into medicine. And number 2, it takes more and longer care to take care of a patient who has an injury on their dominant side. You don't just say left hand or right hand or left side or right side. You say dominant or non-dominant side along with that, because you can say left-handed and just assume everybody knows left-handed. For most people, it's the non-dominant side. But what happens if this one patient is the dominant side? It will take longer with any kind of rehab they need. Okay? They can't do basic activities of daily life without having to relearn them. So it's going to take them longer to do everything they need to do. Okay? So it's important not just to put left and right, which we also don't do, but put whether it's the dominant or non-dominant side of the body. Because then we'll know if additional care, which will cost more to take care of this care, will be allowed to be in the bundle that's being utilized under ACOs in the future. And today, it will allow for better care, and you will show that you're not overutilizing resources. Okay? Any